Okay, we're going to go over some wrongs from June 21st, 2024. First section of the wrongs um, was the difference between anal fissure and internal hemorrhoids. So they gave you that there was a 3-week history of more and more rectal bleeding. Originally, it was only during bowel movements, but then there's intermittent bleeding even between the bowel movements. So essentially, their biggest takeaway between the difference between internal hemorrhoids and anal fissure in this question is that he was having pain, or not, rather the lack thereof pain. So it just basically said that there was no palpable mass on digital rectal exam, tenderness or swelling, but that the blood test still did come up positive. So the only answer that still ended up fitting that perfectly was internal hemorrhoids above the submucosal line, the dentate line, so they say. Okay, the next one is a 10-year-old with ADHD. Then at the end, they say, what are they at the biggest risk for? And they say that they're at the biggest risk for developing substance use disorder. Apparently, this is just something that we were supposed to know. Um, not exactly sure how, but just for future reference, substance use disorder goes with ADHD. All right, the next was testing for whether or not somebody was brain dead. Um, They wanted the apnea test as one of the final tests there. Apparently, according to the American Academy of Neurology, the apnea test can help define brain death. Um, and once the patient is clinically and legally dead, mechanical ventilation should be withdrawn without family permission. Hospital policies can vary on that, but for the most part, I've seen other questions where they've had the brain dead patient and they ended up taking them off of mechanical ventilation without family. Uh, Next one is just make sure you're reading real carefully. So they can say less than 50% stenosis of the proximal left internal carotid artery. So if they're saying less than 50% stenosis, they're just telling you it could be anything, 20%, 30%. So when it's that kind of range, you don't consider doing the carotid enderectomy at all. You only start considering the enderectomy if they are at least a male in the 50 to 75% range. And for somebody like that, if they're symptomatic, which this patient was in the 50 to 75% range, then it would be reasonable to consider the left carotid enderectomy. Okay, here we have a thyroid issue, and I don't know if they meant to be playing with the oral contraceptive or if they didn't, or if they were just saying that the patient had a history of a tumor and radiation therapy, but for one reason or another, they basically said that testing the free T4 or the free thyroxine was a better answer over free TSH. Um, and I think that their reasoning for that is basically that the T4 is a better test for somebody getting levothyroxine. So if they're getting like prescribed a levothyroxine dose, then you want to just check the free thyroxine. Checking the free TSH in that person isn't as helpful. All right, here's another tricky way that they wrote numbers. So it was a 0.2 multiples, means 1/5 of the normal, of the median, not 1.2 multiples, which is the way that you read this. So just keep in mind if they say 0.2 multiples of the median, talking about alpha fetoprotein, then they're talking about the opposite of neural tube defects. And you could have probably read into that more because gastroschisis, omphalocele, and neural tube defect were 3 of the answers. And all of those, in theory, would have increased maternal serum alpha protein. That's definitely what it says in the question, too. So the only other one that was there was Tay-Sachs. And Tay-Sachs, apparently the alpha fetoprotein does not change in that disease. Don't forget that Tay-Sachs has a cherry red macular spot. All right, the next one was Entamoeba histolytica in a 37-year-old who had been to the Caribbean. It said that he went there for like an aid trip or something like that. And he basically has mild cramping abdominal pain that's lasted 4 weeks, but occasionally bloody diarrhea. So you knew it wasn't C. diff, but you went with the leukocyte test here, thinking that maybe it was an inflammatory bowel disease. Um, which maybe it's fair that it was inflammatory bowel disease, maybe not. But in this particular instance, they said which of the following stool studies would most likely confirm the diagnosis, and leukocyte test wouldn't confirm inflammatory bowel disease anyways. So what they ended up wanting here was ova and parasite examination, checking for Entamoeba histolytica. If you were to have done a colonoscopy, you'd find mucosal ulcers that are often flask shaped. Um, and if you were going to treat this, you could use metronidazole or tinidazole, but there are instances where paramycin or iodinoqual are the right answer for that. Okay, yeah, I mean, biostats question that you kind of knew, sensitivity and specificity, where the prevalence is really, really low. So if the prevalence is really, really low, then your sensitivity value, likelihood ratio, your sensitivity value, the way that read it, is way better because it's harder to get a positive if there's very low prevalence. Then the inverse would be true for specificity. So in this particular case, getting a negative test is not as valuable, or the likelihood ratio is not as high for specificity in this person because the prevalence of the disease in this patient population is low. All right, stupid question about a recent HIV diagnosis. So they had just said that 2 months ago, the person found out they had HIV while having a concurrent infection of Pneumocystis jirovecii, and then they just didn't do anything else. Now they tell you that he completed his antibiotic course, and that's sort of misleading because apparently they didn't just leave that person on prophylaxis at that time, and they don't give you a CD4 count here either. So you have no info. You have no CD4 count. You have no viral load. And then they say, well, what's the next best step in management of this patient? And they really, none of these are the right next best step, but the other ones are just more wrong. So referring to another physician for noncompliance, that's stupid. Acyclovir, this is of course for HSV. Now, one thing that was maybe a little tempting here was Zidovudine, because you knew that this was at least an HIV drug, and you're like, but I mean, you got to at least try. But Zidovudine is not an effective monotherapy for treating HIV. It's just not. I mean, there's too much antiviral resistance. So they're just reminding you that basically all current clinical use consists of 3 different medications from 2 different classes. And then that's how you're going to decrease the risk for HIV resistance. So what's left? It's basically between varicella and Bactrim. And so the line of thinking, their line of thinking here is that you still don't have their CD4 count. So yeah, they would get a varicella vaccine if their CD4 count theoretically was above 200, but it's actually a fair assumption that their CD4 count is not over 200 because they had the recent P. jirovecii infection. So for them, they're basically saying you have no viral load, you have no CD4 count. What's the move? Just give them the Bactrim and just move on from there. I mean, certainly there's more steps, but that's the most right step in their line of thinking there. All right, the last one that you got wrong. Nope, never mind. 2 more that we got wrong on this section. So here we have 6 hours after esophagectomy. For esophageal cancer, somebody's blood pressure goes way, way up despite them getting fentanyl. Okay, so they're basically just saying that postoperative hypertension is common and that there's a lot of different reasons why you could get it. It could be pain, bladder overdistension, nausea, vomiting, hypoxia, hypocapnia, shivering, and just emergence from medications that were given during the operation, as well as hypervolemia. So, he's retaining urine. They really make this out to be a whole bunch of different things, like, oh, could it be like neuroleptic malignant syndrome, or could it be just a hypotensive emergency? Like, what's happening here? And really what they're saying is that you don't have any offending agent, and you should just give them more pain medication. You should just give them narcotics. Um, it doesn't seem like a very fair question. We already gave them fentanyl and it didn't help. So to me, it feels like not really the most fair thing, but they're basically saying, well, he's got a full bladder and he's in pain, so give him narcotics, and then in theory, move on to catheterize the bladder and get that urine out of there. All right, so last one that we got wrong here was oligohydramnios, and it's saying which of the following things cause the oligohydramnios, and you chose TE fistula. All right, so TE fistula can create an appropriate connection between the trachea and esophagus, sure, but apparently all it's talking about, all it's caring about, all they mention is that it increases the risk for aspiration pneumonia and respiratory distress. Not super helpful in terms of amniotic fluid levels. What they want you to pick is pulmonary hypoplasia. So they're saying pulmonary hypoplasia is the reason why they have low breath sounds with oligohydramnios and flat facies. It's very sounding very Potter sequency. And then the answer that they want with this Potter sequence is pulmonary hypoplasia. I feel like there's a lot of things to be said in terms of renal function. They're saying congenital malformation of the fetal genitourinary tract, posterior urethral valves, or renal agenesis in this Potter sequence. But then they want to know what's the cause of them having decreased breath sounds. And it ends up being pulmonary hypoplasia.